Brilliant. I think the numbers are pretty much there at this point. No one's really joining anymore. So hello, everyone. Thank you for joining us. Welcome to the latest webinar today from Arthritis Action. This one is Arthritis and Surgery, a Professional and Patient Perspective. My name's Owen. I'm the Communications Officer here at Arthritis Action. Today, we're joined by Professor John Skinner, an orthopaedic surgeon at the Royal National Orthopaedic Hospital, who's going to be giving his professional perspective on surgery for people living with arthritis. Hi, John. How are you today?
Very well, thank you.
Good. We're also joined today by Arthritis Action's trustee, Sarah Bickerstaff, who can discuss her own experience of surgery, as well as Dr. Wendy Holden, who is honorary consultant rheumatologist and Arthritis Action's medical advisor, who'll be joining the conversation too, to discuss a bit about surgery, both from the perspective of a professional and from a patient who's lived through it. How are you both today?
Very well. Hello, everyone.
Hi.
Great. And thank you to everyone attending today's session as well. Thank you to everyone who submitted some questions beforehand. I know we've received a few questions from you guys. We'll be responding to them a little later on in the webinar. If you're watching live and you have a question that you'd like the team here to answer during the webinar, you may see there's a Q&A button at the bottom of the screen. So if you just click that button and then type in your question, and then time permitting, we'll aim to answer it before the end of today's webinar. If we don't have time to answer all the questions, then we'll be sure to email you with an answer in the coming days after the webinar. We'll also be sending you an email with further resources and information once the webinar's over. Just a reminder though on those questions, unfortunately we can't answer any personal questions regarding your specific medical circumstances, but we can answer more general questions about sort of surgery and arthritis. Also a reminder that your cameras are off for this webinar. We can't see you, but you should be able to see us and hear us. So please do feel free to stand up or stretch at any point, depending on whatever you want. So with that bit of groundkeeping out of the way, we will jump into the first section of surgery, the first section of the webinar, which is about pre-surgery, what you can do before the surgery. So Wendy, I believe you have some questions for Dr. John.
I do. So before we start, John, just tell us a little bit about your background, your expertise.
So I'm a consultant orthopaedic surgeon at Stanmore at the Royal National Orthopaedic Hospital. I perform hip and knee replacement surgery and revision surgery, and I assess a lot of patients with arthritis.
Brilliant, thank you. And Sarah, what's been your experience from a patient perspective?
Well, I'm afraid to say I'm no stranger to surgery. I've had back surgery, which was decompression and posterior instrumented fusion. John can explain what that is. I've had both knees replaced, and I've also had a very new thing, which is a Cativa implant in my right thumb.
Marvellous, thank you. So we can hear about that a bit later. You're a walking textbook there, aren't you really, Sarah? Thank you. Right then, John, so you're probably not personally responsible for the entire orthopaedic waiting time that we've got at the moment. And obviously COVID has had a massive impact on orthopaedic services in particular. So do you want to maybe just talk a little bit about that?
So we did have waiting lists before COVID, but if we remember, I think we locked down on the 23rd of March, 2020. And that's when we knew there was going to be a global pandemic of this brand new disease that none of us knew anything about. And so what happened then was that all planned surgery stopped, and hospitals sent patients home who could as many patients home as they could. And then I think everyone remembers what happened in the news, that we had patients being admitted to hospital with this new disease, which caused respiratory problems, which caused renal failure and made patients very ill. And you saw doctors and nurses in ITUs, expanding out ITUs throughout the hospital to treat patients in the first wave. And then things eased a little bit. We did manage to start by August. Remember, that was Eat Out to Help Out. So we had a first bit of recovery and looked like we might be getting it through it. And then some planned surgery and elective orthopedic surgery restarted. And then we had another peak such that by Christmas, it was really short of beds, and we just needed beds for anyone with oxygen. So again, surgery dropped again, and it's never really got back in orthopedic surgery to the levels that we wanted it to be pre the pandemic. It's getting closer now, but what happens is normally from the National Joint Registry, we know that we do about 105,000 knee replacements a year in England and Wales, and probably just under that 100,000 hip replacements a year. And we know from the registry that that number dropped dramatically, and there's probably 100,000 joint replacements that haven't been done that we would have expected to have been done by now. So the numbers are just huge, and the NHS is trying to recover. The problems that we've got is just getting people to prioritize arthritis, because arthritis is not cancer, it's not heart disease, but what we all know is it makes a massive difference to people's quality of life. And we know that arthritis is the biggest cause of disability in the Western world. I mean, it really is. The sequelae of arthritis is a difficult thing. So what's happened, cases stopped being operated on. We've had different hospitals, different areas getting back to some level of joint replacement now, and some really going very well. So we are starting to get through waiting lists, but we got to the situation where there was a number of patients waiting more than 2 years for surgery. The target was to get through those by July, and that's largely been achieved, but we'll need watching because there's a lot of people waiting 23 months, 22, 21, 18. So we've got to keep working at the long waiting patients and the urgent patients, and that's where we are at the moment with joint replacement.
And we've been reading on the BBC and so forth that the government are going to be introducing things like treatment centres and new imaging facilities. Is that going to make an impact on orthopaedic waiting times, do you think?
I think it is. What we need is to have a facility to do year-round surgery for arthritis and a number of other conditions, because everyone hears about winter pressures and the winter crisis, and what that means in winter, more people get ill with pneumonia, with chest infections, and they're in accident and emergency departments, and they need to be admitted to a hospital bed. Once the medical wards are full, the empty beds on a given night are those where someone's coming in to have a joint replacement the following day. And so because they're in the accident emergency department, they go into the beds and people get cancellations at short notice. And that's not a way to do it. What surgical hubs is what we're going for. My hospital doesn't have an accident and emergency department. It has 10 operating theatres, and we're able to operate 12 months of the year. And so the plan now is to get hub centres in every region and ICS so that we can do this surgery, because elective surgery means that it doesn't have to be done today, but it doesn't mean optional surgery. Because I think, as everyone will know, people with arthritis who've got end-stage disease, who need joint replacements, don't get better until that operation's done.
Absolutely. Thank you for that. So while we're waiting for that, presumably people need to do what they can to help themselves. So in the meantime, what can surgeons offer people with arthritis other than surgery?
So there's a number of things that we try before we get to surgery. I mean, surgery is not the first thing you think of. Surgery is the treatment for pain that makes life miserable, that stops you doing things that we can't control any other way. And the ways that we do are painkillers. So anti-inflammatory creams can be quite useful, rubbed into joints. Regular paracetamol, 2 tablets 4 times a day. And if you do take it, the maximum dose, it is safe to do so, and it can be effective. But not many people take 8 tablets in a day. And it is a drug that's used for post-operative analgesia by our anaesthetists these days. Then anti-inflammatory tablets can be useful, and stronger painkillers, what sometimes can be useful from GPs. It's important to keep moving as much as is possible, because if the better, and it's going to be very difficult with painful joints, but the better condition your muscles are in before an operation, the easier the recovery is afterwards. And moving joints helps. Joints are designed to do 2 things: to take weight and to move. And getting them to do those things helps, although it can be very painful. I think the other thing that patients quite rightly fear is that anything that hurts this much must be really bad for them. And I might make it so bad that I can't have an operation. And that's not the case. It's really unlikely that you will make it so bad that the surgeon can't do the joint replacement without your symptoms changing really dramatically and possibly not being able to weight bear. So keep moving, keep walking, take the painkillers as necessary. All sorts of things help. Weight loss does help. It's very difficult to do if you can't exercise normally, but it does help. The way the legs work, the thigh bone is a lever. So when you get up from a chair, because of the length of the thigh bone, you put 3 times body weight through the back of the kneecap. And so for every kilogram lost, you get 3 times the benefit at the knee joint. And that's, so it is worth trying to do as much as possible. Sometimes with the pain severe, injections can help. Long-acting local anesthetic and occasionally steroids. We have to be a little bit careful of that coming up to surgery because we like to leave a gap. We don't want steroids in the joint close to surgery because there is a theoretical risk of low-grade infection, which we really don't want in the joint replacement.
Brilliant, John. Thank you. That was really helpful. What about hyaluronic acid injections? That's something our members often ask about.
So it can help in some people. It's not as routinely offered because it's not a magic bullet. It has a role in some people, but it's not universally effective. I think that would be a fair assessment.
Okay. And another question we often get is regarding cartilage transplantation. So many people think that this is going to be a cure. What can we say to them?
So cartilage transplantation has been going for a long time. It actually works best in fairly small and isolated areas of damage. And it can be used in injured knees where part of the joint surface has been taken away. Perhaps if you think of how a golf club takes a divot, so just a little bit comes out of the joint, and it's very effective in these small focal areas and may stop arthritis, but it's not a cure at the moment, much as we would like it to be for end stage arthritis, where the joint is damaged, the bone just underneath the cartilage is damaged, and often the shape changes. People notice that with arthritis, you often become a little bit bow-legged or a little bit knock-kneed, and that's because one side of the joint is wearing more than the others. But once those happen, cartilage transplantation isn't the answer yet, but there is still a lot of research going on in this field, both with stem cells and with committed cartilage cells.
Okay, thank you. So someone's had knee pain for a long time. How do you decide when you're going to fix that with a knee replacement or a hip replacement?
So what we would do is we'd see the patient, and we need to put the pain and the effect into context of their life and what it's doing to them, how much they've tried to use it, what treatments they've had so far, what the alignment looks like, and obviously what the x-rays look like is what we'll do. Because knee arthritis, hip arthritis, and back pain and back arthritis are all common, and all 3 of those can cause knee pain. So we need to be absolutely certain what the trigger is and what's causing that pain in that patient. Often knees physiotherapy does help. So some exercises and some self-guided exercises that people can do to try and build the muscles, because what happens if the joint is painful, you don't use it normally, the muscles waste away, they get weaker, and you get into a cycle where the mechanics are wrong. And if you can get that back to the point where the muscles build up quite to a level, you can make the function better and the pain better. So that's something that works in knees. It's less effective in hips, but not effective. And so if we've got pain, as I said before, pain that makes life miserable, stops you doing things and can't be controlled any other way, then we start to talk about joint replacement surgery. Often if there's any diagnostic uncertainty, you might do an injection to block the knee. If an injection into the knee will block pain coming from the knee, and if it doesn't have any effect on the pain, then it may be coming from the hip or the back.
Excellent. Thank you.
Just going to jump in. Sorry, we've had a few questions as well, because this is great about sort of knees and hips, but a few people are asking, is that the same case about shoulder replacement or anything to do with shoulder surgery? Is there anything you can say about that in particular?
Sure. Shoulders are, I mean, they are similar joints, but different. The range of movement in the shoulder joint is much bigger than any of the other joints. Obviously, the shoulder is fundamental in positioning the hand in space to allow you to do things, from feeding to writing to tasks. And so, yeah, it's very similar. Again, there's the added complication in the shoulder of the rotator cuff, and depending on how well and there's lots of other causes of pain around the shoulder. So again, it need to be seen, assessed as to what's causing it. Again, injections can be helpful. Again, exercises can be helpful, but if you've got to the stage where arthritis has worn the joint out and that's the cause of pain, then shoulder replacement is a treatment. And if the rotator cuff has gone, then people do reverse anatomy, which is a special design of shoulder replacement that can also compensate for the damaged rotator cuff muscles.
Super. Someone's asked, what's the difference between a half knee and a whole knee replacement?
So good question. The knee's got 3 compartments: the inner half, the outer half, and the part at the back of the kneecap. The commonest form of arthritis is medial. It's on the inside of the knee, and it can be sometimes in complete isolation. It can be that there's also some disease in the kneecap. And what we find is that pain at the front of the knee, it tends to be worse down hills, down slopes, walking up and down stairs, particularly downstairs. If that's the pain, then that's almost certainly coming from the front of the knee. And so if you've got predominantly medial arthritis, the doctor or surgeon will take the history, work out where the pain's coming from, look at the x-rays of all parts. And if it's just medial, then you could have either. A partial knee replacement is a slightly smaller operation in terms of slightly lesser complications. Recovery is slightly quicker. The function can be really good because you're retaining the cruciate ligaments in the middle of the knee and the other joint compartments, but there is a higher chance of it needing to be redone in the next 10 years. And if you get pain coming downstairs, it's possible that that partial knee replacement won't get rid of that pain. So that's a trade-off that the surgeon and patient can make. With a total knee replacement, it is a bigger operation. It does take slightly longer to recover, but the chances of needing it redone in a lifetime, depending on the age that you have it done, and most are done around 60, I mean, most are done between 65 and 75, not all, it works in all ages, then the chances of having it redone in a lifetime are small, 4 or 5%.
Super, thank you. Owen, you're going to ask a couple of questions now, I think, aren't you?
Yes, we've had a few questions. Thank you, everyone who's asking questions in the Q&A as well. Please do keep it coming. We'll try to answer as many as we can. There's a few here, just asking basically about how likely it is if they're having replacement surgery in their 60s, how likely it is that they might need more surgery in 5 to 10 years. You've sort of answered that now, but what would you advise to these people who are being told, oh, maybe wait a few years before you get surgery or anything like that? James?
Sure. I mean, it's good advice when you can manage the pain. When I started my career, we said that it should last 10 years, a joint replacement. But what's happened is the materials have got better and better and better. And what we really want is joint replacements that can last 30, 40, 50 years. And we may have them. I mean, but we just haven't followed them for that long. So I think that materials are better for both hip replacements and knee replacements. That means that the use to fail because they wore out is less and less likely. We've got new ceramics, new types of plastics, and therefore it gets to the stage of how bad the symptoms are. Hip replacement is an operation I've done in teenagers and I've done in patients in their 90s, and I've even redone one in someone over 100. So if the bottom line is, if the pain's bad enough, you're old enough.
Thanks, that's really interesting to hear, actually. I didn't know that you could do it at such an age range, which is incredible. We've had a few questions sort of asking what people can do to help themselves while waiting for an operation. I know you've answered a few sort of things that you would advise for people as well. Sarah, what sort of things did you try before having your surgery? And was there anything in particular that worked for you?
Well, I did try very hard, especially with the knee replacements, but also with the back, to try and sort of generally be fit in other regards. So I did try and keep the exercise up. I found with my knees, swimming, and I'm not talking about, kind of serious pounding down lanes, sort of floating about, but moving your legs. kind of exercise, because it's not weight bearing. I also am a great devotee of my exercise bike, which again, I'm not going to win any races on that. But you know, I do it every morning still. You're mobilizing your knees. I kind of feel like I'm waking them up for the day, and it's non-weight bearing, and you can build it into your routine. So I just tried to do, as John has said, I tried to make sure that the muscles, you know, I did a lot of work. I've got my Swiss ball behind me here. Did a lot of work on my core before my back operation, you know, trying to make other things work well to take the strain off the back. And then with my knees, you know, trying to do exercises, which again, don't have to be heroic things. Arthritis Action's got some fabulous seated exercises that you can do, leg raises, knee raises, things like that, just to kind of try and keep everything moving. And it's a distraction from the pain. And I think it does reduce the pain, but it also makes you feel like you're taking a bit of control over what's going on, that you're not just sort of, oh my God, it really hurts, you know, but yeah, it really hurts, but I'm going to do something about it, you know, so it's kind of good for your head as well, really.
I wanted to ask you another question, John, about people who have been on a waiting list for a long time and then things suddenly get much worse for them. What can they do to try and get things done a bit faster?
So I think that's a very real issue. We know that arthritis is a fluctuating condition that slowly deteriorates, but we know it's punctuated by severe flares, where it's just like the joint catches fire at times and becomes very painful. If your symptoms deteriorate and change, then let your doctor know and let your hospital know. And we do want to know about people going off their legs, going off their stopping walking altogether, because that's not a good place to be, and you start to decondition quite quickly. You lose heart and lung fitness, you lose general fitness, you lose muscle strength. So I think if you've got significant deterioration, then you do have to yell and tell someone, because we know that it can deteriorate. We know people get isolated. The other thing is keep talking to people, because what you do with arthritis is you adapt to it. And I'm sure that everyone will recognize this, that you stop walking for fun, then you stop walking long distances. And then if you can't park close by or the bus doesn't stop close by, you don't go. And then you start going out less and less because everything hurts. And so we recognize all of those things, but if you are deteriorating, do tell someone, because if it's getting bad, then some people do need to be operated on within a month, and that's one of the prioritization grades.
Yeah, absolutely. And I think it's important to let everybody know that you're still there and you're still operating all the time, and people should not be suffering in silence at home.
Exactly.
Yeah, thank you.
I just thought of one other thing I did and still do, ice packs. I mean, I find ice packs really helpful. You know, if I go out for a walk and I just sort of knee or something feels, or, you know, when my hands flare up, I find 20 minutes with an ice pack really just kind of tamps it down.
Great, thank you.
Thanks. We now have a section sort of on the day of surgery itself and when surgery actually happens. So, John, could you tell us a bit more about what actually happens on the day of surgery?
So on the day of surgery, more and more patients are admitted on the day of surgery for the operation, which is fine as long as everything's pre-planned. You'll have already been through consent issues from clinic, and you'll meet the nursing team who will admit you, the surgical team who will be operating on you, and the anaesthetist. And you may well have met you certainly have met surgeon or the surgical team before. And so you come in, and we realize that everyone is very nervous and very anxious because it's quite an unusual thing to do, isn't it? Go in and have an operation. And whereas what the team are doing, this is what we do all the time. And so it is I hope reassuring that this is routine, that people have a well-planned system of how they're going to look after you, how they're going to do the operation, how they're going to get you from one to the other and get you recovering. And so that's the most important thing. If you've got any questions, write them down, because we know it's difficult to remember, and take them in and just get somebody there to go through them with you, which they will anyway. They'll draw an arrow on your leg to identify the correct side. And then you'll be ready for surgery, told which time you're going to be or where you are on the list, and that's where it goes.
Brilliant. And then what complications, if any, are possible on the day of surgery?
So day of surgery, it's the risks. Everyone worries about anesthetic and the risks of not waking up. It really is incredibly rare. It's one in tens, if not hundreds and hundreds of thousands, but people have an anesthetic complication. It really is very safe these days. Things that you worry about, the ones that we worry about, are infection. And so everyone takes infection very seriously. You will have almost certainly been screened for COVID. You will definitely have been screened for MRSA, which is carrying a type of bacteria on your skin, which, I mean, 30% of people carry Staphylococcus on their skin, and therefore some people will carry MRSA. The reason we do that, because if you have got that, it's not an issue. It just means it just needs to be treated and eradicated before you come into surgery. So that's one thing. Then bleeding can happen. It's not that common with hip and knee replacement surgery for it to be significant. And most patients will not need a blood transfusion after either of those operations these days. I suppose the biggest complication after surgery is that it's painful. And what we do is we try incredibly hard to make that not be the case. But I'm sure Sarah will testify to this, that knee replacement particularly does hurt if we haven't got the pain under control. It's a painful operation. The knee is the largest joint in the body. It's really very superficial. It lies just underneath the skin. Hip arthritis is a little bit different. Patients wake up from hip replacement and say the pain's gone. They just know that arthritis pain has gone. It happens sometimes with knee replacement, but it's much rarer. And then what they recognize is that the soreness of surgery is different, and that does get better. And then the knee is painful. And what I would say is that if you've got pain, just yell, tell someone, because all it means is we haven't given you enough painkillers. And it's as simple as that. We should be able to control your pain to a comfortable level, although it is painful for some weeks afterwards, but manageably so. And it gets better.
Good. We'll ask Sarah for her opinion of how her surgery went in a moment, but we just had a question. Someone's asked, is it safe to have an epidural for knee surgery if you have other issues, for example, lower back problems? Or...
Definitely. So spinal anesthetic or epidurals, I mean, the anaesthetist will advise are safe things to do. They're good things to do. And what we want to do is to get patients through the operation so that they're in a condition whereby they can stand up on the day of surgery. That's positive, because that means that surgery's gone well, anesthesia's gone well, the recovery's gone well, you're not feeling sick, you're not feeling dehydrated and lousy, and it's a start to recovery. And some patients will go home on the day of surgery, or will be able to go home on the day of surgery. But if you stand on the day of surgery, the chance of going home the next day will also go up dramatically. And it's reassuring to know that you can do that, and it's safe to do it.
That is reassuring. Thank you. Yeah. Sarah, could you tell us a bit about your experience with surgery, and how did it feel for you on the day of your operation?
Well, in relation to my back, it was kind of, I felt really hopeful. I felt really optimistic. It had been a long kind of haul to get to the point where I was actually having the surgery. But literally, while I was waiting to sort of get wheeled in, I had a light bulb moment. I kind of thought to myself, oh, hang on a minute, this isn't the end, this is the beginning. You know, that actually it's a process. You kind of get rather obsessed with, that's my date for surgery and I'm going in and it's going to get sorted out, which is entirely sort of reasonable. That's how I felt about my back. But when you think about it, actually it's about the work you've done before the surgery, and then the work you've got to do after the surgery. It's actually a process. You know, we focus on the event of the surgery. So that was really helpful when it came to my knees being done, because I really, I had this sort of sense, right, I've got to do some work, keep doing some work before the knee, and then going in. So yeah, I mean, I think seeing it as a process is really helpful, because it means you're in that mindset of it's a kind of it's a journey, it's not a destination. So yeah, having learned that with my back, yeah, I think I would say you do need to get people to listen to you. I did have some issues with my first knee operation because of the back surgery. I wasn't really suitable for an epidural, and I tried to talk to people about that all the way through the preparation stages, and people didn't really listen to me. So and I think it's the other side of what John was sort of saying. It is all very routine for the people that are dealing with you. Of course, for you, it isn't. But that sometimes means, I think, that, people don't perhaps always listen to everything. I kept saying, yeah, but I've had the back surgery. What does that mean for the knee? They go, no, don't worry about that. It'll be fine. And there were some issues there which could have been sorted out. So I think the advice about writing it down, I always do that now. I did that when it came to the knees. Write down, the things, and sort of make people give you answers to the questions that you've got on there. But I think my big take-home message would be, it's a journey, not a destination, surgery.
That's great. Thank you, Sarah. John, we've also had a question here from Lorraine asking, what's the difference in recovery between someone with rheumatoid arthritis and someone with osteoarthritis? Is there a difference in recovery?
So, interesting question. The answer is from the surgery is very similar. The rheumatoid arthritis patients have really coped with a lot of pain, because rheumatoid arthritis tends to involve an awful lot of joints and will have been on different painkillers. It depends on how the rest of the joints are at the time. It depends on, hopefully there'll be an area where they're not flaring up, because they have these flares where everything is painful. So from surgery point of view, it's not too dissimilar. With rheumatoid arthritis, we have to be a little bit more careful. We're careful in everybody with wound healing issues, with infection, just because many patients will be on immune modifying drugs to control the disease. So not too dissimilar, but depends on how the rest of the joints are, and general fitness and general pain levels everywhere else.
I would concur with that as well. Having seen people after rheumatoid surgery, often people will stop their biologics around the time of surgery if they have inflammatory arthritis, so they can often have a flare shortly afterwards. So I would say it's really important to stay in touch with your rheumatology team. Obviously, you shouldn't restart those medications until the surgeon has said it's okay for you to do so. But my experience is that people with rheumatoid arthritis often actually do really, really well after joint replacement surgery, I think, because, as you said, John, they're used to living with pain.
That's really interesting. Thank you both. That's good to know. Well, now I'll start talking a little bit about after the surgery. Once the surgery is done, and sort of what are those next steps? We'll start with you, Sarah. What was it like for you immediately after your operation? And do you have any advice for others, depending on how you experienced it?
Yes, with my back, remarkably, it was a 5.5 hour operation. It was a big thing. Actually, I didn't suffer too much pain after that. But as John said, knees do hurt, and I regard it as, I was very lucky that I went to a thing called a knee school at my local hospital, where I was going to have my first knee replacement done beforehand, where they talked you through, a whole bunch of us, who were going to have knees done, talked us through what was going to happen. They passed around a knee joint so you could sort of hold it and see what it was, and what to expect. And the physio who was doing the talk had knee replacements himself, so that kind of made you sort of feel, this guy knows what he's talking about. But he sort of said, I'm not going to lie to you, it hurts. And I thought, oh well, if they're not even pretending it doesn't hurt, it obviously is going to hurt. Now I found that kind of very useful in a way, because when I came round and I was starting to try and move around a bit, it did really hurt. But I thought, yeah, but I was told it would really hurt, so I don't have to worry about this. This is kind of, you know, what I was told to expect. So I think you just, with knees, my hips are fine, amazingly. I think with knees, yeah, it's going to hurt. It's bound to, you know, you're putting weight on something that has literally just been, no disrespect, John, hacked to pieces, reconstructed. Of course, it's going to hurt. And you just have to get up and move around. And when I had the second one, I remember everybody was sort of like, you know, I was going to go, bring me a Zimmer, you know, are you sure? Yeah, I'm up, you know, people saying, I expect it hurts. Yeah, it really hurts, but I want to get out of here. I want to move on. I think you just have to, if you know that, I think it's oddly reassuring and it wears off. And as John says, you can say, give me the painkillers and move on. So I think, you know, other things about after surgery, I mean, do the physio before, do the physio after. And, you know, it's small things. I've got one really good tip that I always try and pass on about for knees. I borrowed my daughter's skateboard. No, I didn't start skateboarding around on my new knee, but I used to have it under the kitchen table as I was sat there with my foot on it, and I just used to roll it backwards and forwards, and you could do it for kind of half an hour at a stretch, because you know, it's not weight bearing, but you're keeping that knee moving, you know, and that's what you want. You want a good bend in that knee as it heals. And so there's funny little things like that, you know, the exercise bike that I also, you know, quite small things, but which are really, really helpful. And second time round, you know, the physio was saying to me, well, what are you doing? And, you know, your progress is incredible, but it's because I benefited from having learned, you know, through the first one of these little tricks and funny things like, you know, the skateboard, etc.
We have a question here, yeah, which is quite relevant to that for you, John. Someone asking, why do I have to get up so soon after surgery? Because my physiotherapist, this person says, made them get up very quickly, even though they were still in a lot of pain. So what's the idea behind that?
So the idea is to get up, get upright, get out of bed and get going, because you can do. I mean, it is, again, I take that, it is two things that make you not want to do that. One is being in a lot of pain, and the other is feeling sick. Nausea is very debilitating, and it's something that we do need to get control of. Either of those, they should be controlled. And then it's just better to get up and get moving. After any form of anesthetic, it's good to get upright, get the chest upright, because it works better in an upright position. And this generally, people tend to get better at the rate at which they first start getting better. And that's true in lots of things. And I totally take what Sarah said. Knee replacement or surgery is not something you just turn up, have done to you, and it's all okay. It's a partnership. Everyone's got to work at it. You've got to work at it. Your therapist's got to work with you. Your surgeon's got to work with you. The nurse has got to work with you, because it's particularly with knee replacement, it hurts if it's not controlled, and you've got a big cut over the front of the knee, and everyone's telling you to bend it. And if you think about it, if you cut your finger, the only thing it wouldn't occur you to do is to bend it. Whereas we have to do that with knee replacements, and we've got to get them bending to 90 degrees and beyond as soon as possible. And it's helpful to do so. So why do we do it? We want people up as soon as possible. It is actually better for you. You do recover better, and it's easier to control the pain, and whether it's distractions, as Sarah said, but surgery's not done to you, it's done with you, and it's a partnership getting better.
That's really interesting. Thank you.
My surgeon said a very good thing to me about that first time round with the knee. He said, I can guarantee you I will do a really excellent knee replacement. It's up to you whether it works or not.
Really good way of looking at it, yeah. You've both discussed sort of the pain that does come with it, and it's almost a part of it that you will feel afterwards. And people are asking about sort of painkillers as well, and can I ask for more painkillers next time? This person was only given naproxen after the first one. And someone's also asking about longer term pain, if it continues, what they should do.
So good thing, pain should get better after joint replacements. not everyone gets completely pain-free, particularly after knee replacements. Some people do have ongoing symptoms. Remember, we're not taking it back to a brand new knee that you were born with. We're taking it back to something that is mechanical, made of metal and plastic, we know can work and bend and do things, but it does rely on having good muscles around it to control it and to optimize the function. So those are the sort of things. And if you've got pain, just tell someone. We're worried about people being on stronger and stronger painkillers, particularly opioids, because they do make life harder in hospital, and obviously they can't just stop those on day one. Sometimes we have to tail them down because people become physiologically hooked on them. Their body starts to expect them and need them. So those things have to be watched. But short, sharp courses of even very strong painkillers are safe. For something we know that's going to get better, particularly post-operative pain, it's not a bad time to have a short, sharp course of painkillers to allow you to do exercises, to allow you to build the muscles, and then stop them with the expectation that you will. And if pain goes on for a long time, we need to look for what's causing it, if there's a chronic pain condition or if there's a neurological pain condition, which are slightly different.
Okay. In terms of some of the ways that you can recover here, we have a great question from Richard, who basically asks if there are any particular types of exercises which are good or which are bad. He mentions he's a Morris dancer and so jumps around and hops a lot. Is that good or bad, or would you only recommend certain things with recovery?
So Morris dancers, I suspect, have good leg muscles. Like all dancers have got good leg muscles. And so that will stand in good stead. I think Sarah hit the nail on the head earlier in that when you've got a lot of pain, low impact, non-weight bearing exercise are the best. And so when the wound's healed after surgery, or when it's painful, when the knee's painful or the hip's painful before surgery, exercises in the water are really good. Swimming is fine. Do any stroke that you like. We take it as given you're not going to do Olympic world record trying breaststroke, trying to kick your knees dislocated, but gentle breaststroke is fine. And the other thing that's good is walking in water. And if pools have got the same depth all the way down, walking lengths, you'll always see people power walking in water. What they're doing is the water is supporting the joint, and the buoyancy supports the joint, and the water resistance helps them exercise the muscles, so they get much more out of it for low impact exercise. So walking in water is very good early on, and exercise bikes are good too, particularly for knees. And if the knee doesn't bend enough, just put the seat higher. The higher the seat is, the less you have to bend the knee per revolution. And again, low impact and good for the leg muscles. But if I say with the exercise bike, if one knee is painful, really make sure you're exercising the muscles in that leg, because it's very easy for the other leg to do 90-something% of the work, and you actually don't do anything with that leg. So just make sure you feel the muscles burn, do it slower, and make sure you feel the muscles activating.
And I assume that would be the same for other replacements as well, if you're getting other parts of the body, is that right?
Yes, it is. I mean, shoulder replacements, obviously talk to your surgeon about when you can move, range of movement exercises. They often will limit it early on till the soft tissues heal, and then go for range of movement with shoulders and elbows. But yes, the principles will be very similar.
Great. Someone also has asked, when can they drive again after a hip replacement or a knee replacement?
So if it is your left hip or your left knee, you can actually drive as soon as you can comfortably get into the car, because the right leg's normal. If it's the right leg, what we say is 6 weeks, but the answer is as soon as you're comfortable to sit in the car, and as soon as you can do an emergency stop. And so that means a level of comfort and pain control that allows you to do that. So it's generally about 6 weeks for most people on the operated leg, if the operated leg is the right leg, or if they've got a manual car.
Very useful to know, thank you. Great, we're still getting lots of questions through. Thank you. Again, if we can't answer all the questions in time, we will try to email you in the coming days as well with some responses. We've got someone who's asking about security in airports and metal detectors. Will they go off, and what can you do once you have a replacement surgery, or any recommendations?
It's a good question, and it's the one that everybody asks. It really is, because it's a worry, isn't it? And I think that the answer is, it depends what level of sensitivity they set the equipment at, and it depends on the sort of security level of anxiety at the time. But the answer is yes, they will be detected. And if it goes off, if you just tell them, look, I've had a knee replacement or I've had a hip replacement, those handheld scanners, they'll just put it over your hip or your knee, and they'll know very quickly. So it won't delay you. I mean, I've been through phases of giving patients a letter just to say they've had a hip replacement or a knee replacement, and but I don't think it's necessary. I think the airport security staff are very switched on to these things now because it's such a normal thing to have had done.
Yeah, I always set them off absolutely routinely, and as I'm going through, I kind of go to the person beckoning me through, metal knees, and they kind of go, oh, come through, beep 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 beep, and then they put me in the thing, or they do the it doesn't hold you up. And I mean, in some countries, America, in many American airports, they actually have a special, if you say this, there's a special sort of section you go off with all the other robots. So yeah, it happens, but it's not it's doesn't delay you by more than a few seconds, half a minute maybe.
Right. Oh, brilliant. Wendy, I know you're looking through the questions as well, so please do shout if you see it.
Yeah, we've had a few quite different questions really about, there's a good question here. Are some prosthetics not available on the NHS? And I think that's reading between the lines of those is the implication that sometimes if you have a surgery done privately, you will get a better prosthesis. What do you think about that?
I would think that's not true. All of the implants are available in the NHS, and I'm not aware of anything that you could have done privately that you can't get on the NHS.
Absolutely. And how do you decide what prosthetic materials you're going to use in your replacements? We know that some people have metal on metal hip replacements and some people don't, for example.
Sure. So metal on metal hip replacement is a good example. That was one that we don't use anymore. So it was the large diameter metal on metal. The metal was cobalt chrome alloy. We've been using cobalt and chromium implants in orthopedics since the 20s, and in hips sort of 40s, 50s. So the materials are safe. The problem with metal on metal was rubbing cobalt chrome against itself, against another piece. It produces ions of cobalt and chromium which go into the body and can cause reactions. And so no one gets a metal on metal total hip replacement anymore. A few people younger people, more active, men might get a cobalt chrome metal on metal hip resurfacing, which still works well, and it was safe. And it's two things. It's how it's put in. So you want a surgeon that does a lot of them, and you need to have a very detailed discussion about what the benefits and risks are. So for most people, a total hip replacement will be either cemented or uncemented, or the stem will be cemented and the cup uncemented. The standard bearing surfaces now are either a metal cobalt chrome head on polyethylene. New highly cross-linked polyethylene is a superb material that we've had for probably almost 15-20 years now, and it really does make a difference. And all of the hip replacements with polyethylene will have this material. So metal on polyethylene or ceramic on polyethylene, or sometimes ceramic on ceramic in young people, are very hard wearing materials. I always say that it's not ceramic as in teacup ceramic, it's ceramic as in what Formula One cars and Ferrari makes brakes out of. So it's a really hard material that can come together without wearing away. And that's the attractive part of it. Knee replacements are pretty standard. They tend to be cobalt chrome tibial components, and either cobalt chrome or titanium tibial components, again with polyethylene or plastic in between.
That's great, thank you. So Stephanie's asked if you need both knee and ankle replacements, what should you do first?
Knee.
That was easy. Thank
So
you.
start proximally. Same if you need a knee replacement and hip replacement, get the hip done first. For ankles and foot surgery, definitely get the knee done first, because the knee surgeon might realign the leg to where it should be, and then the ankle surgeon can plan on where the leg is, not where they hope it might be.
And presumably you might find out that the second pain is improved and you may not need the surgery anyway, potentially.
Exactly, yes.
Margaret says, how are the muscles attached to the replacement joint?
So muscles, how should we do this? The hip replacement, most of the muscles you you displace or you just move out of the way. There's 2 tendons that you take off the bone. I do what's called a posterior approach, which gives me all the access that I need. I can extend it if I need to, and the function is very good after surgery. And then what we do, we get these 2 tendons and we drill holes into the bone, pass sutures through the tendons, through the holes, and tie them over the top. So they're tied very securely back onto the bone at the end of the operation.
Clever stuff. Very clever stuff.
We had a good question about, can you discuss sort of anterior versus posterior surgery recommendations and things like that, John?
Sure. So there's the anterolateral, which involves taking off 2/3 of one of the big muscles. But I think what the question is getting at is the direct anterior approach, which is done through an incision right at the front of the hip, and it does very little muscle detachment. It moves things out of the way. And for a surgeon who's experienced in it, it works very well. There is possibly slightly quicker recovery in the first 6 weeks, but beyond 6 weeks, I'm not aware of any significant advantages. So it might be slightly quicker recovery. Both work well, but what you want is your surgeon to be comfortable with the approach and have been doing it for some time.
Very interesting, thank you. Oh, sorry, Wendy.
One says, if the shaft of the hip replacement snaps and has to be repaired, how likely is it to happen again? Hopefully not too likely.
Sure. So it's one of these things that we do sometimes see. It's if the metal stem of a hip replacement breaks, it's got to be removed and a new one put in. And what generally happens is the surgeon will put a slightly bigger and a slightly longer one in the next time, because that's what we do with revision surgery. And I think it's no way is it inevitable that it'll happen again.
Great, thank you.
A few people also are asking, so we discussed sort of hip surgery, knee surgery, a bit of shoulder, sorry. Some people are asking as well what the options are for finger surgery or toe surgery if you have bad arthritis there.
Sure. So go to foot first. I mean, the feet, as we know, are very complicated. They are a sprung tripod with 28 bones, 5 layers of muscles, lots of tendons, and they get used an awful lot. And so the forces can be very big. The common conditions in the toe, the tripod is underneath the ball of the big toe. So that joint, if that's got arthritis, it's quite a common source of arthritis, and that can be very painful. And so, yes, there are very effective treatments. And if there's a bunion there as well, correcting it and getting rid of the pain or treating the arthritis can be effective. Sometimes it involves stiffening the joint. So yes, that works. And lesser toes, again, depends what they are. Often they can be fused or treated with injections dependent on where they are. So that's the first thing. Again, hands, the commonest place of arthritis is at the base of the thumb. And that's very disabling, because what makes us humans really is the ability to oppose the thumb and to use the hand dexterously. And so if that's painful, then it can either be removed or it can be replaced. Sarah's brought one with her, and so there are treatments for that which can be very effective. So yes, I mean, it's the hip and knees are just the commonest ones, but arthritis affects all joints in the body, and there are treatments for all of them.
Perhaps I could say something about my hands. I have really very severe arthritis in my hands. I really don't have any joints left in the fingers. If you see the X-rays, it's right, they're rather shocking. And I have had this implant in my thumb. It was going to be a trapeziectomy where they cut a bone out, tighten up the tendon. But I'd heard about this Cartiva implant, so I asked my surgeon about that. And he was quite excited because it was something he wanted to get into doing. So to quote, he said, well, if you're up for it, I'm up for it. He had to have someone come down and kind of, with him when he did the surgery. And the advantage of the implant is that there's no messing around with the tendon, because the problem when you have the trapeziectomy in the thumb, as I understand it, is that they tighten up the tendon, and then, you know, obviously getting the strength back in the thumb and protecting that tendon while it's still been messed around with is critical. Whereas none of that's happened with the implant. I mean, they go in there and they sort of slip something a little bit like a contact lens in round the joint. So that thumb is pain free, whereas prior to the surgery, it you know, it really was a problem. So, I mean, he would do other things like my fingers fuse naturally. I'm doing that on my own without surgical intervention, but obviously they fuse in weird shapes. I personally, I haven't quite understood the benefit of having them fused, but I think it's probably a pain thing. You know, if they're keeping you awake, if they're hurting. I mean, my grip function's pretty rubbish really, but again, I do the physio for my hands. I think it's the thing with my thumb was it had got to the point where I really couldn't stand it any longer. So that's why I had it done. I think surgery on other fingers, you know, the success rates, John, they're not fantastic, are they? I mean, you know.
I think it varies. I mean, it's a good point. I think patients with most experience of this would be the inflammatory arthritises and the rheumatoid patients, which can have very specific diseases. And there are replacements for some of them, but I don't know enough about the results to comment any further.
It's a great conversation. Thank you. It's very interesting to know. We've had one question from someone who's asking if leg length is already slightly shorter on one side because of degeneration, for example, what's recommended sort of to ensure uniformity or anything on that side if the legs are a bit different? So
good question. It's something we always talk about with hip surgery, not so much knee surgery because it's less of an issue with knees, but with hips. First of all, with arthritis, the leg does tend to shorten, but you may not notice it. And it shortens because the cartilage wears away, which shortens it. And then the other thing is the most comfortable position for a hip is not out straight, it's bent slightly, because that takes the pressure off the capsule. And what the body does with arthritis, it puts fluid in the joint to act as a cushion and a lubricant. And by just bending the hip up a little bit, you take the pressure off the fluid and decompress it, but that shortens the leg. If you think about it, if you bend your hip a little bit, the leg's functionally shorter. And what the pelvis often does is it tilts down a little bit. So if your legs feel different beforehand, tell the surgeon. They can look at it and whether it's true or apparent, whether it's actually short because of something that's happened during growth or during the arthritis, or whether it's because of the capsule and the way it's being held. And then the surgeon will do everything they can to correct it. Sometimes if you've had the pelvis tilting down a little bit on that side, because your body's already compensated for the shortening, then when you have a hip replacement, it can feel longer on that side. Sometimes it is, but it often feels longer. And usually what happens is the pelvis goes back to its original position. It starts to feel more and more normal. So tell your surgeons about it. They will always be part of the consent to say that leg length discrepancy after surgery is something that can happen, because they've got to balance the tension and the stability of the joint against length sometimes. But they will always plan to try and make the legs feel and be the same length afterwards.
That's brilliant. Thank you, John. I know we have a few more questions that we haven't been able to answer within the hour, but don't worry, we do have a list of all your questions. We'll try to email you in the next few days with a response. But for now, thank you, Professor John, Dr. Wendy, Sarah. This does conclude our webinar today on arthritis surgery, both from a professional and a patient perspective. If any of you are watching today and you'd like more information on the subject or on anything else in relation to arthritis, we recommend that you visit our website, which is www.arthritisaction.org.uk. If you go there, you'll find a number of useful resources that will help you self-manage your condition, whether that's sort of in the lead up to surgery or as you recover afterwards. And it also includes detailed information on exercises, dietary information, well-being resources, and tips for staying connected with other people. If you're watching this, a video of this webinar will be made available shortly on our YouTube channel. And if you're watching it live, you should receive a link to it as well through an email once that's available. So just watch out on your emails and you should receive that in the next few days. All that's left for me to say is thank you to Professor John Skinner, to Sarah Bickerstaff and Dr. Wendy Holden for answering all of our questions today. And thank you to all of you for joining us. We hope you all stay safe and healthy, and we look forward to hearing from you soon. Thanks,
Bye.
everyone.
Thank you.